Now, part of your management for hematologic disorders, the ones you did last week, you presented HIT, TTP, hemophilia involves blood transfusions, correct? Okay, so we'll practice blood transfusion today. Let's cover first the testing part. So this is page 899. Keep in mind that these are still IV solutions. So this involves the same skill you practiced and learned last week with setting up the IV. It'll be the same with a few differences in the detail because we have a different tubing. But since it's still an IV tubing, the principles will be the same. Which are the two parts of the tubing that you need to keep sterile? Both ends, right? Okay, so these and then the other end, right? All right, so what are the blood products that we're going to be transfusing? We have several. We will discuss the procedure later. Let's look at the different blood products first. Table 28-4, these are the different blood products you will be administering throughout. The three most commonly transfused, and therefore these are the three that I'm going to be testing, are packed red blood cells, platelets, and plasma. Again, they are packed red blood cells, platelets, and fresh frozen plasma. In fact, these were the three that were mentioned in your presentations, correct? You did mention cryoprecipitate in one of the disorders. Cryoprecipitate is another blood product. It's processed still from the same whole blood, meaning when you donate, who have donated blood here? Okay. So when you donate whole blood, they can get many different blood products there, meaning they can sell it 3-4 different ways. So they can get cryoprecipitate from that, they can get platelets from it, pool it, not a lot of platelets, but they can pool platelets, meaning pooled platelet means they can get 10 blood donors, whole blood from 10 blood donors, and then extract platelets from those 10 blood donors. In fact, they don't even have to be of the same blood type because platelets do not have a blood type antigen on it. Make sense? Meaning, when you donate platelets, you can donate to anybody because there's no blood type on the platelet. Make sense? Okay. Packed red blood cells obviously have blood types, right? So you can only get blood type from specific people. We'll test that as well. They what?
The pack, the one that you said has a
That's just a story. Okay, that's okay if you missed it. Just pick it up in the recording. Okay, so whole blood is what you donate. Takes about 10 minutes, right? Sit there, they stick you with a big needle, drain blood 10 minutes, then you're done. Then you give you a snack, right? So we seldom transfuse whole blood. Whole blood is very rarely given. We give packed red blood cells a lot. Again, it's just part of the business. A red blood bank is also a business. They have to stay in business in order to stay operational, correct? Even if it's, let's say, New York blood centers, yes, hospitals still pay them. Somebody has to pay the processing, right? There's staff in the blood bank, right? Yeah, so it's a resource. Of course, the donors don't get paid, although they get points. Okay, I'm a regular platelet donor, so I get points, and which you can convert to gifts, right? Just a little incentive to keep people coming. Although it's not really, I mean, you're there for a life-saving act, right? It's not really necessary to get paid. Although some people do sell blood. So the three we're testing are packed red blood cells, platelets. There are two types of platelets. We will do single donor as well as random is also called pooled platelets. So this is the platelets that I meant earlier, wherein because there are very few single donor platelets, donors, sorry. Why? Because it takes 2 hours at least to donate single donor platelets. And you sit there with that needle in your arm for 2 hours. Right? It takes a long time. Whereas, how long did it take for whole blood? 10 minutes. Okay. So multiply by so long, okay, to get a single donor platelet. So this one's only reserved for typically cancer patients, immunocompromised patients get single donor platelets. Everybody else can get pooled. Pooled again is, that's why they call it pool. What is a pool? A bunch of stuff, right? Okay, so this can be up to 10. So they can get 10, they'll grab 10 whole blood bags, extract platelets from them, put in the machine, extract platelets, and put all those platelets in one bag. Then they get the same amount as a single donor. All right, so a single donor platelet's about 200 to 300 ml. Bag of packed red blood cells is about 300 ml. So you'll see them on the bag. When you look at your bag, it will tell you the volume here. How did they know how much volume? Well, it goes through a machine, okay? And then they weigh it. So by volume, they estimate that let's say this one says 300 ml. But of course, each bag, the real one that you will get from the blood bank will vary. Some of them will be 310, 301, various volumes. So the test questions will be, who will get what blood product? For instance, packed red blood cells, who will get that? Here's your answer. So who are they? Okay, so of course, anemia, well, blood loss patients, hemorrhage patients. So what about surgery patients? Okay, so anyone who lost blood. Typically, the threshold for, and it's on the procedure, the threshold, at least today, used to be different during my time. Now they don't transfuse unless it's below 7. During my time, we transfuse below 9. Now the threshold, because blood is very scarce now, so they lower the threshold down. We don't give you blood unless your blood count, your hemoglobin falls below 7. Now, unless you are actively bleeding. So let's say we see that your hemoglobin is still 9, but then we have evidence you are bleeding. Okay, we can see you're losing blood through your rectum, for instance, or you're bleeding. Okay, you've been shot, you're bleeding, we can't stop the bleeding. So we don't wait. But by the time we check it, let's say it's 9, okay, what do you think that was 10 minutes ago? What do you think it is now? Okay, so you're losing it constantly, so that's an exception. For platelets, look at the indication. When platelets are below 5, what's the normal platelet count? 150 to 400,000. How come they rate so low? Why now? Less than 150,000 is already low, correct?
Yes.
Yeah, why? Look at that. Why is it? Why do we wait until the platelets drop? Most hospitals, though, don't wait until this low. We typically, the threshold for actual practice is 20,000. Below 20,000, you're at risk for spontaneous bleeding already. You start bleeding through your nose, ears, everywhere else. So you stop bleeding spontaneously. But let's look at the technical term. So let's just put it 20,000, okay? 20,000 and below. Or this one technically will be 5 to 10,000 or less. Then you receive platelets. Why? Why do doctors wait so close to the end?
Because they're waiting for evidence or what is decided?
It really
If it
has,
is, okay.
okay, the reason really is two. One is platelets abundant, very few platelet donors. Second, platelets live only 7 to 10 days. So if you transfuse at 149,000 and they only live 7 to 10 days, please put your phones away, or if you need to use your phone, please step out. Very distracting. So do we transfuse early if they only live 7 to 10 days? No. So we wait until we actually need it. Patients absolutely needs it. Does that make sense?
Yes.
Okay. Plus on the donor part, since your platelets only live 7 to 10 days and your red blood cells live up to 120 days. So how often can you donate whole blood?
It's like.
About 45 days, okay? Because it takes a while for you to replenish red blood cells because they live so long. What about platelets? How fast do you think your body replaces them if they live only 7 to 10 days? Slow, you only they
So
die.
it's getting
It
faster.
doesn't make any sense. You will all be dead by now. So that way, that means our body replenishes it really fast. So therefore, how often can you donate platelets? Every 2 weeks. If you can withstand it, that big needle. Okay, so you can donate platelets pretty much every 2 weeks, although they cap you up to a gallon per year. Okay, so if you reach your gallon for the year, no more. Wait till next year, right? Then finally, plasma. Plasma is we do have a plasma bag over there. It's the yellow part of the blood, the liquid part of the blood. Once we remove all the blood cells, once you remove all the white, platelets and red blood cells, what's left is that yellow solution. Again, I'll show you in a bit. So that's plasma. What's left after you remove all the cells? Well, everything else. Plasma is about 70% water. It's mostly water. About 20% is protein. So therefore, based on that alone, who will get plasma transfusions? Mostly water, next, majority protein. Who gets it therefore? Platelets, patients who are low in protein. What else is in there? Patients with, this is given to patients with coagulation factor deficiencies. So therefore, what's in plasma? Coagulation factors are in there. What else? It's used in plasmapheresis. Plasmapheresis is, we'll discuss that during lecture later. We didn't finish from myasthenia gravis last week. I did mention plasmapheresis, right? Or plasma exchange. Okay. So plasma exchange is given to myasthenia gravis patients because what is the nature of myasthenia gravis? What's the problem? Miss Cornett, please put that phone away or step out. Please, this be the last time I mention it. It's wasting the class time. I get distracted. I forget what I'm going to say. So what is the nature of myasthenia gravis? An autoimmune disorder. So the patient has antibodies against what? Acetylcholine what? the acetylcholine receptor. So therefore, who gets plasma as well? Transfusions. Patients who autoimmune disorder patients, so not just, so is it only myasthenia gravis?
No.
There are tons of autoimmune disorders, so all of those patients have autoantibodies, therefore, what does plasma contain also? Antibodies.
That would be take out the antibodies from the plasma.
Yeah, so therefore, in plasmapheresis, this procedure or plasma exchange removes what? The patient's plasma. We can't remove antibodies, it's,
You know what it is?
well, we can't remove just
So the
antibody, we have to
plasma
remove
surface
plasma.
remove plasma from the patient.
Right, remove the patient's plasma, because why? That patient's plasma contains what? Those autoantibodies, those bad antibodies, we take them out, then we replace them with somebody else's protein, somebody else's plasma, that way, which doesn't contain the autoantibodies. Make sense? Any question? Alright. So just those three. Another blood product is albumin. I'm not testing this. Albumin is pure protein, pure albumin. This is taken from plasma. Okay, so they can extract plasma. Plasma comes in a bag like this. Albumin comes now in a glass bottle. They put it in a glass bottle, 100 ml glass bottle, and that's what you transfuse. Typically, they give that for either ascites patients when we drain fluid from their abdomen, because that contains, they lose a lot of protein. Also with liver disease patients, same liver disease patients who get paracentesis, or their liver is shot. They have end stage liver disease, so we give them albumin to keep them alive. And here's the cryoprecipitate mentioned in your presentation last week. So this is pure fibrinogen. Okay, so contains fibrinogen, so helps with bleeding. See, hemophilia A. This is also used in, when was this also mentioned? And DIC, correct? DIC patients also receive cryoprecipitate, because what is DIC? Clotting first and then bleeding disorder. All right, let's go to the procedure now. Blood donation, I won't test. Hopefully, some of you know already what it entails. So you sit there, these are the requirements. So if you meet these, that's why there's you go to a computer first, it's no longer paper. So you go to a computer, and then you answer questions. They'll weigh you, they'll take your vital signs, you'll ask a bunch of questions about your disorders, chronic illnesses, do you have any bleeding, clotting disorders, all that, cancer, HIV, for instance, because they want to, before they stick you, they have to see, are you a suitable donor? These are the criteria. So you're underweight, you need blood. You're in no business to be giving any. Okay. So 8 weeks. So this is 2 months, but in New York blood centers, they'll take you in 45 days. It's acceptable. And you have to be at least 18 or older to give blood. Yes.
So if you're underweight.
No, I mean, if you're underweight and you're skinny,
So you can't give that up. What does that
you
mean?
don't need, I mean, you're in no business giving blood. Go home.
So, but Professor, if let's say after they with the patient and that patient, let's say, for example, 110, will you tell the patient they cannot give blood even though they want to?
We admire your dedication.
But also-
You're a patriot. But go home. Not anymore. Yeah, there's some changes now with the New York Blood Center. They're all based on evidence. Okay, so they see that tattoos don't really right. So certain vaccinations also, it's okay, right? So especially with COVID, even if you're COVID positive, they can receive they can donate blood now. But used to be during 2020, there's a lot of changes, a lot of restrictions. But after that, no, they discovered that this doesn't make any sense. It's not harming the patient. So yeah, go ahead, give blood. Alright, so hemoglobin should at least be 12.5, male or female, so if it's under. And do you give blood? I mean, you need, yeah, your blood's already low, so no, go home, eat something. Take iron. Travels, these are related to things like monkeypox or Ebola, for instance, okay, when you travel to certain countries. Autologous donation means you're giving blood to yourself. So this is done in elective surgery procedures. So let's say you're planning to have a knee replacement or a hip replacement in, I don't know, September. So today's June, so plenty of time. You have 3 months before your surgery. So if the doctor advises you, oh, you'll need a blood transfusion for this surgery. You're gonna lose a lot of blood with the hammer, these things, screw, gonna do a lot of grinding, so you would be losing a lot of blood. And do you want to, they'll give you the option, do you want to bank your blood or are you okay receiving blood from somebody? Some people are wary about, they don't trust the system, especially those conspiracy theories. They're not necessarily, just people just aren't comfortable of the idea of getting blood from somebody. So they have the option, okay, I'll bank my own blood. So they'll donate blood, freeze it, they'll withdraw it come surgery day. Make sense? Okay. So because it's your own blood, are you likely to have a reaction? No, it's your own blood. You just deposited it and took it out. If you won't need it, simply for the rare reason that you won't need the blood transfusion, then you have the option, okay, I'll just give it to someone else. The only thing you can have is a bacterial contamination reaction, meaning sepsis, because can the blood get contaminated during storage? Yes, during the handling, it may get contaminated, so that's the only thing you will get from your own blood. Okay, let's go to the procedure now. First thing you'll need is the indication. Okay, so you met the criteria, hemoglobin's below 7 or you're actively bleeding, patients gets an order. So doctor orders, puts it in the computers, nothing's written now. So it's on the computer, transfuse so many, and they'll have specific instructions on when to give it, how many to give, what to give in between transfusion if there are multiple transfusion bags ordered. And then next is we need consent, correct? Okay. Consent is almost always required. The only situation wherein we don't need consent is during an emergency, meaning you ended up in the ER, we had no idea about your wishes, whether you're, and we can't, there's no way for us to know. You have no ID or anything that says you have Jehovah's Witness, no bracelet that says you don't need blood, whatever your wishes are. We're covered under the Good Samaritan Act, right? So we give you blood. Consent is desired, not really necessary. In a what scenario? Emergency, life-threatening scenario. Okay, so we assume you ended up in the ER, you must need help, right? Because otherwise you wouldn't stay home. So we have the order, we have consent. And then we know they need it. So we have the indication, we verified, hey, blood's low, he needs blood. Next, we have an order. Doctor ordered the transfusion. Third, we have patient's consent. Or what's the exception again? Life-threatening emergency. Okay. Let's go to the procedure. So your responsibility after getting consent, you can, of course, the doctor explains it, why they need consent, and then you can serve as a witness. Doctor can't witness because there's a conflict, right? So you verified with the patient, okay, doctor explained to you, understand? Okay, so here's the consent. You sign it, you can witness, sign as a witness. In the case of verbal consent, what do you do? Let's say over the phone or, okay, two witnesses, okay. Next is, so we have the indication, the order, and then we have consent. You have explained the procedure to the patient, then told them, part of your explanation will be the complications. So you have to educate them on the possible complications and also what to report to you. Okay, so we'll also test that. That will be on the long list of transfusion reactions. We'll get to that later. Next is to have an IV access. IV access must be 20 or bigger. By 20 or bigger, what do I mean? 20 gauge, what else? 18, 16, 14. Should not be smaller than a 20. So 22, no good. Technically, some textbooks say 22 is okay, but no hospital will have a policy allowing 22. No hospital. All will require at 20 at least. That's the smallest gauge for a blood product.
Question, so let's say the patients that already like in emergency, they came in with an emergency, they already have a line. That line is like a regular IV and they need blood now. Let's say it's a 22 or 24 or a 25 they had, whatever the gauge is, but it's not compatible to the blood one. So do you have to do the second line?
Yes.
Cannot go.
All right, so you'll have to study 28-3 and 28-4. That's later in the chapter. Most common reaction you get is a febrile non-hemolytic. Fever, of course, your action for any transfusion, any suspected transfusion is always to stop the transfusion. Stop and then call the doctor. We say stop, you disconnect the patient. I'll show you how to disconnect later. You stop and then call the doctor. Now, febrile, if that's the only reaction, nothing else, blood pressure is okay, respiratory rate is okay, no oxygen saturation, nothing harmful to the patient is happening. So you can you call the doctor and they'll tell you to stop. However, in most cases, the doctor will tell you to give them Tylenol and then continue the transfusion in most cases. Yes.
What if
Again, we'll investigate. The doctor, we can't, that's outside the nurse's scope of practice. Okay, the doctor will decide. So your job is to what? Stop it. Stop the transfusion, call the doctor. They'll decide what to do. Here's the procedure. If the patient receives more than 1 unit of blood, there are 2 possible complications here that could happen. This is someone's blood, right? How did we keep it from clotting? Because this is outside the patient's body. So how is this not clotting? Because when you bleed, your blood drops on the floor. What happens to it? It clots. How come this is not clotted? It wasn't frozen when you were sitting for 10 minutes in the blood donation center. What's in here? Citrate. They put citrate from the tubing, this tubing here that they cut. This is the tubing that went from you, from the needle. So they crimped it. Everything from the line, the tubing to the bag have citrate in it. Meaning, what's in this blood also? Citrate. So did you receive citrate when you got this bag of blood?
Yes.
So how much citrate do you think if you receive 2, 3, or 4 or more bags of blood?
Full citrate.
each time you are receiving citrate. So that will lead to citrate toxicity. Because your calcium therefore will drop. Your free calcium, the calcium that goes in and out of your blood vessels, goes in and out of your heart and your skeletal muscles, will drop because they become calcium citrate. Calcium citrate has only one place to go, in your teeth or in your bones. Calcium citrate is now a huge ass compound. It cannot enter cells anymore. It's too big. So there's only one place for it to go. Where? Bones or teeth. Bones or teeth. So therefore, what will you check if a patient receives multiple bags of blood? Calcium. Okay, so if their calcium drops, you give them calcium. You call the doctor, you receive an order for calcium. This bag, do you know how old this is? This blood, you know how old it is? How do I know how old it is? Okay, there will be a donation date here. So this one, it just says the expiry date, so I know it expires at some point. Are the blood cells in here born on the same day? Do they all have the same birthday?
No.
Are some newly born when I donated them? Are some middle-aged? Some teenagers? Some already 119 days old, about to die the next day? And then when I store this, do they stop aging? Does it
No.
stop the aging process?
No.
They continue to age, right? And die. What do all cells spill out when they die? So when you burn a cell, when you hack somebody, what do cells that are destroyed spill out? Let's say I'm a cell. You hack me in half. What will I spill out? Think of an egg. Egg is in single cell, correct? What's in it? Right, but electrolytes wise, what's in it? Potassium. Electrolyte. So it has potassium. So therefore, the dead cells that are in here, are they spilling potassium? When cells continue to die each day, they die every day, some die every day, they continue to spill potassium. And I'm giving the patient 1, 2, 3, 4 blood or bags of blood or more. How much potassium am I giving to the patient? So what is the other electrolyte I'm going to be checking? So what are those two again? Very good. What will happen to the calcium? Drop because of citrate toxicity. What will happen to the potassium? Very good, children. Okay, so let's time. Yes.
So what is the citrate range? Like, how do you know the patient is in toxicity after you check the blood? There is a minimum range that you have the patient have?
I don't have to check it. I'm checking calcium. That's it.
Oh.
Because I can't, because will the citrate hang around? No, because it becomes calcium citrate. So there's no way to check citrate because there's always calcium in our body, so in our blood. So therefore, once you put citrate, what will become it? Will it stay citrate?
No.
It always has a attraction to calcium. So they get married right away. Put citrate in there, they'll find, oh, want to get married? Okay, yeah, and then they go into the bone for a honeymoon. All right, so let's go to the procedure now.